Unit 8 is Antepartum Nursing. If you look at your outline, you'll notice that there are several different subtopics within this, and so I'll be splitting these videos up a little bit. This is the first one where we'll be dealing with genetics, conception, and fetal development. A little bit later, we'll be talking about the physiological adaptations to pregnancy, psychological adaptations to pregnancy, and how the family as a unit adjusts to the birth of a child. And we'll be looking at the prenatal assessment and basic prenatal testing. We will also be talking about prenatal care and promotion of health with the pregnant woman and the family. So we'll get started. So this is part 1 of Unit 8, and we have some objectives. I split them off from your main objectives for the unit, but this video will only cover genetics, conception, and fetal development. So we'll be looking at the basic principles of genetics. A lot of this will be review, but we will discuss the role of the genetic counselor in pregnancy. We will briefly describe the process of fertilization, which should be equally familiar to you from 9th grade biology and from your college coursework. But we will spend most of our time discussing the growth and development of the embryo and fetus. So we'll go ahead and get started with that. And we're going to discuss basic concepts of inheritance. So again, going back to 9th grade biology, we all know that the gene is the basic structural unit of hereditary material. It's made up of DNA, and genes make up the chromosomes, of which there are 46 in the normal human cell. That gives us the 22 pairs of regular chromosomes, and then 1 pair of sex chromosomes, either your XX or XY. Okay, so those are, some basic terms that we deal with. Genetics is an essential concept to understand for perinatology. There are a lot of people who have issues either with inherited family disorders, and they want guidance from that point of view, or they are at risk for chromosomal anomalies. So when we're talking about inherited disorders, there are 2 basic types. There are the inherited disorders, and there are chromosomal anomalies. And we can spot the risk for inherited disorders when we look at a family pedigree or a diagram called a genogram. And I might be able to give you guys a little bit of practice with that in class. A genogram is a family diagram. The males are squares, the ladies are circles. And inside each one of these, we go back about 3 or 4 generations and see what familial disorders show up in each individual. And from there, we can kind of determine how much risk somebody's at. The chromosomal anomalies are a little bit different. They don't show up from one generation to the next. Typically, they're mistakes that get made either in the process of making a gamete, which is a sex cell, a sperm or an egg, or anomalies that can occur when the cell is dividing, such as when a fertilized egg undergoes cleavage and becomes a morula, and then, blastocyst and all that. So the inherited disorders, we have several different types. Chromosomal anomalies usually fall into monosomies or trisomies, but they can also be translocation, which is when one piece of genetic material gets moved onto the wrong chromosome. They can be deletions, or they can be repetitions, which is when material is either repeated, like a skip in a record, or it's left off. So those are just some of the types of mistakes that the cells can make when they're dividing. So they're the 2 types, and typically a genetic counselor will see people who are at risk for either of those, for having a child with either of those things. Okay, so we'll start with inherited disorders. And the first pattern we're going to talk about. Let's see. Yeah, here we go. Let's change colors and keep them guessing. Autosomal dominant inherited disorders. Okay, now these are thankfully fairly rare, but what happens is that one parent expresses the trait. If that person has children, they will pass along that trait as a dominant, and let's see what happens. We'll do it. Remember those silly Punnett squares? We'll do, say, a B. That's your dominant. That's your recessive. And let's say that disorder is some kind of autosomal dominant disorder. Now you have mom. Mom is not affected. If the two of them decide to have children, you have either a big B, little b, or a big B, little b, or little b, little b, little b, little b. So the choices are basically that you have two children that manifest that dominant trait, and two that are heterozygous recessive. So you only need one copy of the gene to express it. We know that dominant genes are always expressed. They can be homozygous, which means that you have both copies of that gene as dominant genes, but more often they are recessive. Thankfully, there are not that many autosomal dominant inherited disorders, but there are a few. And I remember, when I was younger studying this for the first time, thinking, well, if it's dominant and it's passed from generation to generation, how bad can the disorder be? If this person grew up, functioned well enough to pass on their genes to other people, how bad could the disorder be? Well, examples of this disorder include Huntington's disease and neurofibromatosis. And I'm going to kind of talk about them. So it's interesting. Huntington's disease is a devastating neurological disorder. If it occurred in infancy, then no one would ever pass this on. However, it typically occurs after age 30 to 50. And I have a very interesting case study. If you hold on 1 minute, I'll pull up that lady's genogram and you can see it. Okay, so here it is. And I'm going to circle Mrs. G. This is our patient right here. Okay, she's the affected female. And you can look back through her chart. She got the disease from her mother, who got it from her father. Okay, it was a dominant gene. And so each time this individual had a child, there was a 50-50 chance that that child would be affected. Now, the interesting thing about this case, she was a 47-year-old woman. And they thought it was sort of a family curse. She came from Venezuela, and in the village that she was from, there were several cases of this, probably because of consanguinity, which is when people marry within maybe a couple of generations of their own family. Anyway, the family story was that they had been cursed and that so many of them would suffer from this disease, the symptoms of which start out with personality changes and sometimes aggressive behavior or forgetfulness, tremors, Parkinson's-like tremors, and then it progresses to what's called Huntington's chorea, which is a lot of involuntary movements and leads to dementia similar to Alzheimer's disease and gradually takes this person's life. It's a progressive degenerative neurological disorder. But in the beginning, it looks like mental illness, and by the end, it looks like end-stage Alzheimer's. So this woman thought she had been bewitched. And when she had exhausted all of her options with the curanderos, she finally went to see a doctor who referred her for genetic testing. And they found that she had a lot of repeats on 2 alleles of this dominant gene. When they did the pedigree, they looked back and they saw that her mother was affected. And when you look, there are 1, 2, 3, 4, 5, 6, 7 children in the family. and 1, 2, 3, 4, 5 of them are affected. Something that you might have to explain to patients who have a hereditary disorder is that it's not that 25% of their children or 50% of their children will have the disease. It's that each child has a 50-50 chance or a 25% chance. And that's important because some people will think, well, if I have 2 children and one of them's already affected, then I'm sure to have a normal child now. And that's not true. Every child has the same chance of developing the disorder. Interestingly enough, as I was reading this article, this woman has 4 sons, each one of whom has a 50% chance of developing this disorder at some point in their lives. And again, it's a devastating disorder. She's 47, so her children are all of the age where they may start manifesting symptoms within the decade, and they may be passing on their genes to children. So they have declined genetic testing, at least as of the printing of the article, which I thought was very interesting. I would think that most genetic counselors would encourage that those people get tested. I'm going to talk a little bit about neurofibromatosis because I have another interesting case. I went to college with an individual. What neurofibromatosis is growths of benign tissue, but benign tumors that grow in nervous tissue. They arise from nervous tissue. So you can have tumors that arise from the brain, spinal cord, nerves. And he did have some lumps that we could see under the skin. I'm not sure where they originated from. But I didn't know that he had this disorder when I went to college with him. We knew that he had sort of an ataxic gait, and there were a few speech difficulties, but he was really kind of a nice guy. He worked on the school newspaper. He ended up having a career in journalism, and maybe 10 years later, I was working at Capitol Health, and I glanced across our high-risk list. We keep a list of people at risk for various complications during pregnancy and childbirth. So there was a woman with his last name on it, and it was kind of a distinctive last name, and I thought, I wonder if she's any relation. Well, maybe a month later, they came in, and she delivered. And it turned out that it was this person. They had pre-implantation genetic diagnosis to make sure that the child did not have neurofibromatosis. And now, again, you're saying, well, this guy was able to go through college and get married and have a job and create a family. How bad could this disorder be? Well, I'm going to throw another term at you called variable expression. And what variable expression means is that some people will get a very mild form of the disorder, and some people will get a very severe form. And we don't always know which ones will be which just based on their karyotyping. And so this was a decision that was guided in part by genetic counseling. And they had said to this person that, you may be very functional and fine, but this disorder can be painful if it presses on the spinal nerves. It can cause a lot of different neuropathies. It can cause serious developmental disability. And we just don't know if a child affected with this gene will end up like you, functioning fine without too much deficit, or if this will be a child that needs a lifetime of care. And so they chose for pre-implantation genetic diagnosis, which is one of the big advantages to genetic counseling. Okay, so our next type of inherited disorder is the autosomal recessive disorder. And with an autosomal recessive disorder, each parent has the altered gene. And so, you know what? I'm going to change the letter for that. Hold on, let me erase that. Okay, so their genotype might look like this. Okay, where they have a copy of a dominant gene which protects them from expressing the copy of the recessive gene which carries the disease. Okay? Now, each parent has the altered gene because a child who has the disorder has to have 2 copies. They have to be a little s, okay? If you have 2 carriers, they are at 25% risk with each pregnancy of having a child with a disorder. And examples of this are sickle cell trait, PKU, cystic fibrosis, and there are many, many other diseases. And let me sort of give myself a clean board. I don't know why this isn't erasing as well as it should be, but okay. So if you have a mom, I'll make my letters smaller so we can do our little Punnett square kind of activity. Okay, sorry about that. Okay, so you have a mom who is heterozygous. She carries the trait for sickle cell disease. She does not have sickle cell disease. She marries a guy with the trait for sickle cell disease who does not have sickle cell disease. And the way that that can work out, they can have a child with both normal copies. Or they have a 50%, they have a 25% chance of that. They have a 50% chance of having a child who, like them, is a carrier for this disease. Okay. Then they have a 25% chance of having a child who actually suffers from sickle cell anemia. Now, of course, if you have, this gets a little bit more complicated. If you have a parent who actually displays the disorder. If instead of two carriers, you have somebody who has the disease and marries somebody with the trait, and I have seen sickle cell patients get pregnant, even though it's a nightmare when they do. Pregnancy and sickle cell are not a good combination. Sorry, I'm just erasing. Okay, so if you have a mom with sickle cell and dad carries the trait, well, now you have a carrier and you have a child with the disease and you have a carrier and you have a child with disease. So they have a 50% chance if they have the disease and marry someone with the trait, they have a 50% chance with each pregnancy of having a carrier and a 50% chance of having a child with the disease. So these are people who definitely need genetic counseling to decide whether or not they want to take that risk. Because 50-50 are not great odds in any event. We start to offer genetic testing to women over the age of 35 because their risk of Down syndrome becomes about 1 in 100. So think about that when you're talking to people who have a 25% risk or a 50% risk of having a child with a disease that is painful and shortens their lifespan. So that's your autosomal recessive disorder. And if you have questions about any of this stuff in class, I'd be happy to clear them up. I know I'm talking really fast, but again, this is really just kind of a recap of what you learned in 9th grade biology. So let's move on. Okay, so moving on to X-linked dominant inheritance, and this is actually not common either. Disorders that are dominant tend to be very, very rare because people who suffer from them try not to pass on their genes or in effect are prevented from passing on their genes. And when I was looking up the X-linked dominant disorders, I really couldn't find a lot of things that I commonly see. And some of them, to be honest, even though they are X-linked dominant because they're on that X chromosome and they are dominant genes, they're caused by de novo mutations, which means that they are brand new genes from a mutation that spontaneously occurred at some point. So there aren't that many of these. There are a couple, and I won't name them because they're not that important, but this is how it works. If the father has the affected gene, which means he has the disease, 0, none of his sons will get it. 100% of his daughters will. Okay, let's see if I can make that make a little bit of sense. Okay, so what that means is dad is, he's XY, and we'll say that the blue color means that that's the gene that's affected. And mom is, XX, but both of her genes are recessive, okay? Dad is dominant, his gene's always expressed. So when they have a son, he's only giving his Y chromosome, which doesn't carry the disorder. He's giving his X chromosome to both of his girls. And so he has a 100% chance if he fathers a girl that that child will have the same disease that he has. You know, I don't know too many traits like that as far as major inherited disorders, but that is an X-linked dominant. Now, if the mother carries it, hold on one sec, let me erase some of this stuff. And we'll give her the blue for dominant. I just have to erase that, so I have a little bit of Blackboard here. Okay, so if the mom has one copy of the dominant X, she has a 50%, let me try and get back in there, there's a 50% chance of passing it on to her children. Sorry, change colors and keep you guessing. And those children could be either male or female because mom donates an X chromosome to each child, regardless of the sex. Sex is determined by the father's chromosome. And so that is how an X-linked dominant recessive disorder or dominant inherited disorder works. So our next topic is X-linked recessive disorders, which are much more common than the dominant ones. For obvious reasons, anytime you have a disorder, a recessive trait is more likely to be carried on because people don't know they have it and they aren't affected by the disorder. So they occur most commonly in males, again for obvious reasons. Women have 2 X chromosomes. The chances are one of them is going to be normal, and the normal one will express itself because it's dominant, whereas the abnormal copy will be recessive and, you know, kind of be silent. So our typical pattern is a female carrier, and she has a 50% chance of passing it to her children. If the male gets the affected gene, he will have the disease. If the female gets the gene, she will be a carrier like her mother. And diseases that fall under that category include hemophilia or hemophilia A. I mean, there are different hemophilias. And Duchenne muscular dystrophy. Give me a second, and muscular dystrophy. There are 2 types of muscular dystrophy, but Duchenne is pretty heartbreaking for parents because they watch their little boys lose it's a neuromuscular disease, and it's very difficult for parents to accept this because most of the time the child develops normally up into a point and then starts to lose their neuromuscular function. Okay, and the next thing that I want to talk to you guys about is chromosomal anomalies, because this is probably the most common referral for genetics that we see. We have moms who are advanced maternal age. They're starting to refer dads for advanced paternal age. But we typically see this offered to mothers because all of our oocytes, all of our egg cells, are completely, we have them all by the time we're a 9-week fetus ourselves. And over time, the quality of those eggs can deteriorate. They undergo one last cell division right before they emerge from the ovum or ovary. And during that cell division, the older eggs tend to make those little mistakes that we talked about. There are 2 basic qualities of mistakes. There are trisomies, and these are probably the most common. Trio smiles. Interesting. Spell check or autocorrect. The upgrade to this app has an autocorrect that just makes me a little bit crazy. Trisomies are when you have 3 copies or 3 chromosomes when you should have 2. So you end up with 47 chromosomes instead of 46. The common ones that we see are 21 is the most common, and that's your Down syndrome. We also sometimes see 13 and 18. Many trisomies, 13 and 18, spontaneously abort or become stillbirths. Some will live, but not for very long. It's uncommon to see either 13 or 18 live past the age of a year. There are isolated reports of children living longer than that, but there are some very severe disabilities, and we can kind of talk about that a little bit. There are monosomies. I don't think you have to get too wrapped up in this. A monosomy is when only one chromosome, one or the other gamete, either the sperm or the egg, is missing a chromosome. And the most common one you see, oh, jeez Lord, look at that. Okay, the most common one that you see is Klinefelter syndrome, where I think it's the Y chromosome is missing, or it's one of the sex chromosomes is missing. Most trisomies and monosomies, most of these are incompatible with life. And up to 50% of spontaneous abortions or miscarriages, as they're more commonly known, are caused by chromosomal abnormalities. Trisomies and monosomies are not the only anomalies you'll see. There are also things like translocations, where a piece of genetic material is transferred inappropriately from one chromosome to another. You can see deletions where information from a chromosome is missing, like a short arm. I think Cri-du-Chat syndrome. There's a short arm missing of the chromosome. Or you might see repeats. Fragile X. There's an allele. If you get so many repeats of something, you'll start to see the disease. I think if it's more than 11, you see mental retardation and facial features and things like that. So chromosomal anomalies can be fairly common, just that most of them end in spontaneous abortion and some of them end in stillbirth. So what does genetic counseling offer people who are at risk for a genetic disorder or at risk for having a child with a genetic disorder? A genetic counselor is definitely a referral you want to make. If a routine prenatal assessment or a preconception visit raises this issue. What happens at a genetic counseling appointment, the first thing that will commonly happen is that they will sit down with you and have a conversation about your family history. And that conversation will result in them doing what's called a pedigree, which is like a family tree, or a genogram. Okay. And a genogram is sort of a pictorial representation of your family tree. And I'm not sure if I can get the shapes feature to work. Sometimes it does, sometimes it doesn't. But here is, oh yeah, there it is. There's a circle. Circles represent females, okay? Squares represent males. And now it's not working again. Sorry. Try it one more time. Sometimes I get really excited about this stuff and then it just doesn't work. Nope. Okay. Well, I'll draw it with my finger. That's fine. So a square would represent a male member of the family, or the patient if it's a male. And a genetic counselor would sit down with both the husband and the wife, or both the parents, prospective parents, and sit down and draw out these family trees and let them know that you start to see patterns of disease. Now, if you have obviously, if you have a family that's of Greek descent and you're worried about thalassemia, you're going to look at that pedigree and see if you had anyone who died from some strange anemia, or if anyone had a diagnosis of thalassemia. By the way, here are some groups that benefit from genetic counseling. We've already talked about people who have known inherited disorders, and we've talked about people who are over the age of 35. Also, we have risk factors. If you are Ashkenazi Jewish, French, Canadian, or Cajun, you have a risk for Tay-Sachs disease. Ethnic groups can have risk for cystic fibrosis, sickle cell anemia, beta thalassemia, alpha thalassemia, and I think I said cystic fibrosis. There's one called Canavan disease. But sometimes you'll be referred because of your ethnicity. You can also be referred. We had a couple who was from Guatemala, and they were like second cousins, I think. So consanguinity is another reason for referral to a genetic counselor. And so what they would do, like I said, is draw this genogram or pedigree, and it's helpful to know what your family history is. Of course, if you're adopted, you won't, which creates sometimes a little bit of an issue. But what you end up doing is say, this is my family tree, and I have a bond by marriage to my husband. We can do his family tree separately, but I go back up, okay, and I have mom. You kind of go through how old they were when they died or whether they're still living. You talk about the different diseases, and there are many familial diseases. We talked about them in physical assessment. Mental health disorders have a familial component. Developmental delays, if you have autism in your family, sometimes Fragile X is connected with that, so they might want to look at you for that. So this is one of the things that they do in genetic counseling. The other thing that they can do is make you aware of options in regards to genetic testing and diagnosis. There we go. We got rid of that and get rid of my nice little circle. There we go. They can talk to you about genetic testing. Now, you can get your karyotype done, and that typically involves a blood sample. Sometimes they will swap your DNA from like your tissue sources, like the inside of your cheek. They can do testing for specific disorders. And if you hold on, I'm just going to go see what my little man is crying about. Okay, and he's all right. Then we start talking about prenatal genetic testing, examples of which, if mom and dad do IVF, we can do pre-implantation genetic diagnosis, or PGD. And that is where they test the embryo and make sure that it doesn't have the disorder that we're looking for. And this is particularly helpful for people who have these devastating disorders where there's a 25 or a 50% chance. It's very good for people with cystic fibrosis. Cystic fibrosis, people are living longer with it, and they are finding cases of it that are not as severe as the classic clinical picture. But for a long time, it was a death sentence for a child. They really rarely lived past 20. So this pre-implantation genetic diagnosis can be very important in cases like that. Other things that they can do is recommend prenatal testing such as CVS or chorionic villus sampling. And when we start talking about fetal development and we look at the placenta and how it forms, you'll start to see what the chorionic villi are. They're little finger-like projections of trophoblastic fetal tissue. And we can also sample some of the amniotic fluid in a test called an amniocentesis. And amniocentesis is typically performed at about week 16, week 14 through 20 it can be done, which is kind of late if people are thinking about making decisions about the pregnancy. By the way, amniocentesis, although it's commonly used for genetic testing, can also be used for other purposes, and we'll talk about that later when we start talking about antenatal assessment. There are other screens. Now, the maternity 21 or NIPS testing, take a sample of maternal serum. And this to me was always interesting because I was always told there was never any mixing of fetal and maternal blood. Well, it turns out that some genetic material of the fetus does get into maternal circulation. And so they can sample and find little pieces of it and test for chromosomes. It's very limited at this point, and they use it to diagnose trisomy 13, 18, 21, and they can determine fetal gender from the maternal serum. So that's sort of an interesting test, and it's non-invasive. They might recommend a test called the quad screen based on risk, or the first trimester screen. Okay, and the first trimester screen correlates an ultrasound picture of the nuchal translucency, which is a fold at the fetus's neck. And this is usually done around week 10 to 12. And they do this with the maternal serum looking for alpha-fetoprotein. And we'll cover some more of these in our unit on antenatal assessment, so don't worry, you will hear these terms again. But these are tests that might be offered to people based on their session with a genetic counselor. Genetic counselor gives information. They really don't do care per se. They can interpret data and they can educate the patient and help them make an informed choice. So that is what genetic counseling does. Okay, and now for a very brief discussion of fertilization. And this really is a review of your 9th grade biology. Fertilization happens in the outer third of the fallopian tube, also referred to as the ampulla, and there it is for you right there. That's where all the magic happens. Conditions have to be more or less just right for fertilization to take place. Generally speaking, the ovum only has about 24 to 48 hours before it disintegrates and is no longer viable. Cervical mucus has to be favorable. The fallopian tubes have to be patent and have room for the sperm to swim. And the sperm have to be motile and, intact. Okay, so there's a picture of a sperm cell swimming through cervical mucus. And that came from A Child is Born, which I think he did all with endoscopy attached to normal cameras. Let's see if I can find another picture for you. Yeah, there we go. And this one's huge, but I'll just get it smaller. Okay, so you have the egg, which is good for 24 to 48 hours, more towards the 24-hour side. And you have sperm, which can live, they say, up to 3 or 4 days, but typically only 24 to 40 hours as well. Conception will generally happen about within 12 hours of ovulation. So, one sperm can penetrate, which gives you the 23 chromosomes from dad and 23 chromosomes from mom, and then we have a single cell, which then, now we're into actually fetal development, we can get out of fertilization, becomes the zygote, or the fertilized ovum. And this is a picture of cleavage, which is the first cell division. The cell first divides into 2 and very rapidly becomes bigger. By day 3, we have what is called a morula. Nope, that's not the one I wanted. Hold on. The morula is about 16 cells. It has undergone division that many times. There's the picture that I wanted. And there, oh, hold on. That one has to go away. Bye. Okay, so there is your morula phase. And at this point, this little mass of genetic material is still sort of making its way down the fallopian tube and towards the endometrium, where it's going to implant and find a little home. Let me find a picture of that for you. Okay, and there's the blastocyst implanting in a process also known as nidation. I'll spell it out for you. Let's see what the autocorrect does with that. Oh, yeah, I knew it would happen. And I don't know how to turn it off. All right, nidation is the process that we're looking at. And it kind of looks like somebody landed on the moon there, but the idea is that there's a decidua, the lining of the uterus, that hasn't been shed. It kind of buries itself in there and makes a little home. And at this stage, the pre-embryonic stage, we're still in. The first 2 weeks post-conception, the first 14 days, is known as the pre-embryonic stage. Let me just put that somewhere. This stuff does get a little more interesting. Okay, so the zygote is now known as a blastocyst. And we have an inner cell layer, which is known as the embryoblast. This is going to give rise to all of the baby's tissues, and the trophoblast, which is going to become the fetal part of the placenta. And I always think it's really interesting that when you have your kids, they do half and you do half. They undergo this miraculous transformation from this tiny single-celled object into this very complex human being. And your body goes through this massive transformation, and you make part of the placenta and they make part of the placenta. It's reciprocal right from the very beginning. So I always think that's a little bit interesting. But the trophoblast, like I said, is going to release tissue that becomes the fetal part of the placenta. And this process of implantation takes place at about day 5 or day 6, give or take. And what's going to happen is that the progesterone that the mother's body secretes at this part of her cycle makes that endometrium thicker and easier to implant, and is more vascular. And we're going to talk about that. Maybe not right this second, but I do want to talk about how the placenta develops, because at this stage, the arteries that are in the placenta are still like little corkscrews. And I'll discuss how they sort of remodel in a normal pregnancy so that there's more blood flow to the baby. But for now, let's just kind of realize that there's a lot of blood flow to this area from the influence of progesterone. Now the trophoblast, that layer of cells, starts secreting enzymes that digest the surface of the lining of the uterus, the endometrium. Okay, and that's going to help it embed into that surface. Usually a normal implantation happens in the upper part of the posterior wall. And why is that important? It's important because sometimes it doesn't, and then we end up with a problem known as placenta previa, because the first thing that's going to implant is that trophoblast, and that's going to make your placenta, and then there's going to be sort of a stalk, and then the embryoblast, which will develop into the baby. So where implantation happens is important. And one of the reasons, I mean, I guess this stuff all gets connected by 6 degrees of separation. But one of the reasons that it's important to note that normal placentation happens that way, it'll help you understand why we need to reduce the risk of C-sections. Because C-sections create a piece of scar tissue where abnormal placental attachment can occur, and you have a higher incidence of placenta previa, placental abruption, and other placental problems when you have scar tissue in the uterus from a C-section. Not that we don't do them when they're necessary, just like I said, everything is connected by 6 degrees of separation. Anyway, so the first 14 days we said was the pre-embryonic stage. The next stage that we get to is the embryonic stage, and this is a really important phase of development. In the embryonic stage is where all organ development takes place. A process that we know as organogenesis. Okay. Now, this is the phase that mom, if she knows about her pregnancy, can be somewhat ambivalent, can be in denial, and if she's having problems adapting to this pregnancy or accepting this pregnancy, she may be involved in risky behaviors. So let's see what happens during the embryonic stage. Okay, so at this stage of the game, and we're only talking about 2 weeks post-conception, the fetal tissue or fetal cells are already differentiated into different, what they call germ layers. There is the ectoderm, which is the outer germ layer, and from this layer we get our skin, our hair, our nails, sweat glands, and you get some of your endocrine system, your pituitary gland, the medulla of the adrenal gland. You'll get some of your nervous system structures, your eyes, your ears, mucosa of your nose and your mouth, and your salivary glands. So the ectoderm is pretty important. The mesoderm is the middle layer, middle germ layer, and from there you get some deeper tissues, the dermis as opposed to the epidermis. You get the bone, cartilage, skeletal muscles, cardiac muscles, smooth muscles, kidneys, adrenal cortex, bone marrow and blood. And all this stuff is in your book. It's on page 35 of Derm and Chapman on table 3.3. The endoderm is a lot of your internal organs, your esophagus, stomach, intestines, your lungs, your gallbladder, your thyroid, your pancreas. So the tissue is already differentiated. And things begin to happen very quickly at this stage. Now, I wanted to show you, let's see if I can find that picture of the neural tube. And it was kind of amazing to me to look at this. I didn't know what I was looking at first. I thought, wow, that's really weird looking. But what it is the neural tube starts to develop really in the 3rd week of pregnancy, and you're talking about 20 days, 22 days, 24 days. It starts off as a really crude tube, what ends up becoming the control center for your entire body. You know, your spine, your brain, your nervous system, all starts in this really crude tube. And you can see in this picture that it's open at the top. Okay, it's also open at the bottom. Remember that development all goes from head to toe, from middle to outward generally. But the spinal cord is one of the very first things to deliver. And all this little gray tissue in here, that's brain. And you can see it's already separated into hemispheres. And this is very early. I think this is day 22 post-fertilization. And remember that at day 14, this was really just a ball of cells that had 3 little germ layers, and it's already rapidly differentiating and dividing. Well, what happens in spina bifida, I know we talked a little bit about genetic inheritance, probably a little more than you really needed, but multifactorial inheritance. Now, some people are genetically predisposed to spina bifida and other neural tube defects. But if they have enough folic acid, they'll generally still develop normally. If mom is in a state of relative deficiency of folic acid, this neural tube doesn't close quite right, and we end up with the neural tube deficits. Okay, I'm just going to make a little note that this is neural tube. You know, and I know sometimes I get a little bit repetitive because I was talking again about folic acid, and it might be the 4th time during this presentation, and I know you're going to hear it again in class, and I know it's going to be on quiz questions, and I know you're probably going to hear it again when you speak with Miriam from March of Dimes. But some things for you should be like peanut butter and jelly or spaghetti and meatballs, and neural tube defects and folic acid should be always linked in your mind, that if you don't want to have a baby with spina bifida, every woman of childbearing age, from the minute she starts having a menstrual period until she goes through menopause, and maybe even for a little bit after that, should be taking a folic acid supplement, at least 400 micrograms. And I'm not going to write that down because you're going to hear it a lot, but you can take a note if you want. It's 400 micrograms. And most prenatal vitamins might have 400 or 800, just to prevent that specific defect. The neural tube defects that we see are spina bifida, which can be divided into spina bifida occulta, which is generally of no clinical significance. It's just something that you might find on an x-ray incidentally. Then there's a closed spina bifida where the skin covers the defect. There are myelomeningocele and meningocele, and those are your spina bifidas. And I have some good pictures of those, but I probably won't show them right now, just in the interest of moving on because we're still in fetal development. And then you have defects at the other end of the tube where that brain is, where you get anencephaly, where the brain never fully develops. Maybe you have a brain stem, and this is kind of a sad phenomenon. And I have seen families that have dealt with this prenatal diagnosis of anencephaly. And what happens is the part of the brain that tells the baby to move and kick and grow is intact. So mom is still feeling those little kicks and flutters and falling in love with her baby, who has no cerebral cortex. Just that, like I said, that brainstem. and it's really most of the time incompatible with life. Some babies live a short period of time, but generally speaking, anencephaly is a major lethal disorder. So that was your neural tube. Now, other things that happen early in development. Okay, so this picture is a picture of a 24-day-old conceptus with the fetal heart. And you can see it's just like a simple structure with a fold in it. It sort of was a tube, and then the tube folded over. And eventually, it becomes this very complicated structure that we know of as the human heart. But you can see it starts out, it's just a tubular heart that starts beating. Some sources say day 18, some sources say day 22. I believe your book says somewhere in week 4. But it is very early that this stuff happens. And speaking of birth defects, we haven't talked about teratology yet, and we won't for maybe until the end of this part of it. But anything that interrupts the normal process of development at this early stage of development can end in a heart defect or a neural tube defect, or a cleft lip or cleft palate, and we'll see that too. But so here is the picture of that. The neural tube is just closing up at the top here on day 24. It's still open at the bottom and starting to close. The heart, let's see, it started out as this little like tubular thing that looked almost like U-shaped. This picture's not great. But it folds over. Eventually it has the 4 chambers, and it starts to beat in a very coordinated fashion. And then it just refines all through the embryonic period. But it starts really, really early like that. And now I said I would show you a picture of the human face. These are the ones that are hard for people to take a lot of times because they start out so alien looking. There it is. Okay. But you can see where the lip, you can see where a cleft lip might happen here, right where that part is still open. Between week 6 and 9, certain medications and certain other teratogens, which are chemicals that cause anomalies in a baby. Here, let me get rid of that arrow. There we go. Well, anything that interrupts that development can cause a cleft lip between weeks 6 and 9. Cleft palate is usually between weeks 7 and 9. And palate closes a little bit after the lip closes. But those are examples of multifactorial inheritance where there's a critical period in development. Let's introduce that concept. And then something interrupts it. And there's a genetic susceptibility, and that's when you get your disorder in a multifactorial inheritance pattern. It explains why not every baby from every mother that took an anticonvulsant gets cleft lip and cleft palate, just the ones with that genetic susceptibility. The study of the play between environment and genetics is called epigenetics. Let me spell that. And that is a growing area of interest because we're finding a lot of things. Autism, diabetes, a lot of these things rely on the interplay between the environment and genetics. Okay, so we've talked about that. So we know that the spinal cord and the heart start forming in about week 3, week 4, they start to beat. Let's move forward a little bit. Now, weeks 4 and 5, we start to see a lot more differentiation. You start to see the development of the eye. you start to see, limb buds. Okay, the spinal cord keeps developing. You're starting to see organ development, the liver. Pretty soon you'll start seeing the ear develop. I believe that's in week 6. And the kidneys and lungs start to develop in about week 6. So let's make a little box for them. Lung tissue starts to develop. Ears, kidneys, limbs continue to form. And it's all happening very rapidly. And I think I will include that little, it's like development on fast forward kind of movie. Here, let's just move that down there. So, you know, where week 2 and 3 and 4 we're really concerned with the rudimentary structures, the most important organ systems in the body, the spinal cord and the brain. Now we're starting to branch out a little bit. Eyes, ears, arms, legs, kidneys, lungs. Anyway, by the time you get to the 8th week, or the end of the 8th week, you're no longer in the embryonic stage of development. You are now in the fetal period. And organogenesis is more or less complete. Here, let me get this picture out of here. And this is a picture of an 8-week-old fetus. And as you can see, the fetus looks a lot more human. All major organ systems are developed. At this point, it's just a matter of refinement in structure and function. Those organs will continue to develop, but they are already there. Anything that's present in the newborn is already formed. And so I think, since we just finished talking about the embryo, I'd really like to talk about teratology and the subject of teratogens. Teratogens are anything that cause a threat to normal growth and development in the embryonic period, or the period of time before the baby is born. And we can consider medications, viruses, smoking, alcohol, let's see, even vitamin overdoses can be teratogenic. X-rays, so radiology or radiation, all of these things are considered to be teratogens. Now, teratogens can interrupt development at various points, not only the embryonic period. I mean, sometimes you'll see things like congenital rubella will cause deafness while hearing is developing. Hearing isn't really fully functional until about week 24. Radiation can cause problems all the way up to week 18 of development. But the reason I want to call your attention to teratogens, we used to think that the placenta was like a magic barrier, or at least that was the scientific theory way back when. And then we had the thalidomide crisis. And all this happened a really long time ago. It was before I was born, mostly. Thalidomide was a medication that was given in Europe to prevent morning sickness in pregnant women. And a lot of women took it, and you ended up with severe birth defects. Like flipper-like arms and legs, if they developed at all. So because of that, doctors began to realize that there really wasn't a magic barrier. In fact, anything that a woman is exposed to, or almost anything that a woman is exposed to, can cross the placental barrier. The placenta really wasn't meant to protect the fetus. The placenta was meant to be a means of exchange of nutrients and oxygen. So it's a much more permissive type of structure. It lets a lot of things through. So we need to be aware of that, especially those of you who end up working in other areas, that there are medications, there are treatments that we do for people, anesthesia gases, that can have harmful effects on a developing embryo or fetus. So fetal development continues in weeks 9 through 12, and the face looks more, as I said, human. The ears start to take on a more adult structure. Eyelids close by week 10. They'll reopen sometime in the second trimester, about 24, 25 weeks. The long bones continue to form. Everything goes from head to toe, so the arms are still longer than the legs. The head is still about twice as big as everything else in the body. You start to see a lot more movement, or a little bit of movement of the fetus. Red blood cells are being produced by the liver. And you can start to hear the fetal heart rates somewhere between weeks 8 and 12. And as I say in the next video, be careful of telling parents that you can hear heart rates at weeks 8. Sometimes you can, sometimes you can't. Depends on how good your equipment is, how thin the mom is, and whether that baby is positioned in just the right spot. And I know I'm telling the same story that I will tell again in the next video. But I have been called to the ER on a few occasions and to auscultate heart tones on somebody who is 7, 8, 9 weeks pregnant, and it is always a stressful thing unless I find them on the first try, because they assume automatically that if you can't find them, there's something wrong, and I have to sit there and calm them down and say, no, your baby's heart is about the size of a sesame seed right now, and they don't like the sensation of the Doppler being placed on them because it causes sound waves to go through the amniotic fluid, so they try to stay away from it. Every once in a while at week 9, 10, I'll catch that sound if I dig in just the right spot, right over the pubic bone, and I kind of angle it inwards. But when you're auscultating for heart tones before 12 weeks of gestation, and you may hear them, but always caution the parent that you might not, so that they don't automatically assume that something's wrong when you go looking for it. But that's weeks 9 through 12. And then we get to weeks 13 to 16, which is a period of very rapid growth. And by this time, at 13 weeks, remember at week 8, the baby was about 5 centimeters, and now we're at about 9 centimeters, which is almost double. There's fine hair that starts to develop called lanugo. You know what? That is an 8-week fetus. Let's get rid of that. And that's better. That is a 15-week fetus. And you can see the ear is becoming more refined all the time. We've got fingers, we've got toes. The bones begin to ossify at this point. Prior to this, they were made of cartilage. We see that the skin is really translucent, and you can see the blood vessels right underneath. And in this umbilical cord, you can see, at least I can see, at least the 2 arteries. There are 2 arteries in one vein. We'll talk a little bit more about the structure of the placenta and the umbilical cord when we're done with this. At this point, there's a lot of active movement. The baby makes sucking motions, swallows the amniotic fluid, breathes the amniotic fluid, which helps lung development. We have bronchial tubes that are branching out. The liver and pancreas are also sending out secretions. Fetus is capable of producing its own insulin at this point. So development is well underway. And here we see a fetus at 20 weeks. And you can see that this fetus looks much more distinctly human. And here you can see the amniotic membranes. The eyelids are still fused shut, but this is the halfway point. And at this point, the baby measures about 8 inches long, or 19 centimeters, which is double what it weighed just a few weeks ago, or what it measured just a few weeks ago. The fetus weighs about a pound, so 435 to 465 grams. The body is covered in lanugo, which is like a fine downy hair. You see a lot of it on the shoulders. As the fetus matures towards term, this hair will fall out, but one of the ways you can usually see a preterm baby is that the baby is still kind of hairy, still has some lanugo. baby's starting to lay down some brown fat, which will help maintain blood sugar and body temperature when the fetus is a newborn. The eyebrows and eyelashes are beginning to form. The fingernails are present on fingers and toes. The muscles are developing, and the fetus is active. Now, at this point, mother can usually feel the baby move. And this is a major sort of turning point in the psychosocial aspect of pregnancy. And what I think is interesting is that hearing is starting to develop at the same time, and becomes more complete at 24 weeks. By 24 weeks, the baby can localize sound and will turn towards a loud noise. In fact, we sometimes use this when we do vibroacoustic stimulation. If we want to elicit some fetal movement, you might use an acoustic stimulator to get that baby to move. At 24 weeks, the baby's length is 28 centimeters. It weighs about 1 pound and 10 ounces. The eye is structurally complete. It's about to open. The eyebrows and eyelashes have formed. And at this point, the baby has a startle reflex. So if mom, again, we talked about hearing. If mom is exposed to loud noise, you'll feel the baby startle. The entire body is covered in vernix at this point, and surfactant is beginning to be produced. And this is important. By no means is that surfactant adequate to support the fetus at delivery, but at 24 weeks, we now consider this fetus to be viable. If born, it could survive with a lot of support. Now, viability has changed over the years. It used to be that at 28 weeks we considered things to be kind of sketchy. I think before that maybe 32 weeks. But at this point in time, with the addition of surfactant, a 24-week fetus, if born, could survive with a lot of support in NICU. Now, the incidence of brain damage and retinopathy and other complications of prematurity are pretty high still, but this is considered viability. And that's important when you're making clinical decisions about resuscitation. They even can sometimes resuscitate at 23 weeks, although the statistics are really not promising for intact survival. And by intact survival, I mean that the baby lives and does not suffer major deficits. But by 24 weeks, we do consider that fetus to be viable if born. And this is still the 20-week fetus. So, okay, so here we have a picture of a 28-week fetus. Between 25 and 28 weeks, there's a lot of growth that occurs. And at this point, every few days, the chances of survival and the chances of survival without deficit increase dramatically. More and more surfactant gets produced in the lungs, and although the lungs are underdeveloped at this point, they are capable of some gas exchange. Eyelids open and close, and the baby continues to grow and put on weight. And from 29 to 32 weeks, we continue to see increased refinement in all the organ systems. Particularly, the lungs are developing rapidly, although they're still immature, and if the fetus were to be born now, would require support in the NICU again. And we'll sort of revisit that concept when we talk about high-risk antepartum and the administration of corticosteroids. Between 24 and 34 weeks, we try to get those lungs to mature a little bit more if we think the fetus is at risk for being born early. At this point, the fetus is growing in muscle, fat, and they grow rapidly in length and in weight. 33 to 36 weeks. Now at this point, the baby has a pretty decent chance of doing very well at birth. We have to be careful. 34 to 36 weekers in particular, we call them the late pretermers if they're born, and they are like the great imposters because they look like babies, just small ones. And they don't look like they're going to struggle, but they do sometimes have issues maintaining blood sugar, maintaining temperature, maintaining respirations. But the central nervous system has matured. The lanugo, that fine downy hair, is starting to disappear. Baby's putting on more fat. The skin is getting less translucent and less wrinkly. At this point, if you were to shine a light at mom's abdomen, given that she's not morbidly obese, the baby would have some kind of reaction to it and try and turn away from the bright light. And by 36 weeks, you've got a fetus that weighs about 5.5 pounds to about 6 pounds. They're absolutely capable of doing well on the outside, but again, with support. And you can't just kind of leave them alone and not expect to monitor them and give them any support for a long time. If they were 35, 36 weeks, we thought, that's really okay. They're just about cooked. But we're finding out more and more that there's a lot of incentive to keep pregnancy going as long as possible, because growth and development in utero continues until about week 39, 40. Now, there's a discussion. Your book says that 38 weeks is considered term. According to ACOG, they're trying to change some of these categories. They're talking about 34 to 36 weeks being a late preterm. 37 to 38 weeks would be an early, or 37 to 39 weeks would be early term. So 37 weeks was what I always considered to be term according to ACOG and A1. But your book says 38. And really, ACOG prefers that no elective inductions happen until 39 weeks because babies mature at all different rates, and some of them just aren't ready. Growth and development still occur. Mostly the baby's gaining weight. And the central nervous system is still maturing a little bit. Lanugo is gone. The skin is pink. There should be lots of subcutaneous fat. And you see the amniotic fluid sort of diminish at this point. As the baby gets closer to birth, you just run out of room for it. So you start to see about 38 to 40 weeks, the baby will start to settle into a pattern of sleep-wake cycles that mimic what they do at birth. Okay, and now I'd like to talk a little bit, we're going to have to backtrack a little. We're going to talk about the placenta, the umbilical cord, the amniotic fluid. So the placenta develops pretty much as soon as implantation starts, that process begins. And like I said, the trophoblast, which is the part of the blastocyst that is going to form that placenta, starts secreting enzymes so that it can dig into that decidua. The decidua is the lining of the uterus on the maternal side. Okay, now the uterine wall, I'm going to call your attention to it here. You notice that there's a lot of blood flow to that area, and you don't see it here, but inside the lining are these little flimsy, look like bed springs. They're called the spiral arteries. And the reason that they're coiled like that is that in most cases, mom isn't going to have a fertilized ovum. She's going to have menstruation. And so these spring-like spiral arteries can sort of constrict and contract very easily to keep she's not mom at that point, keep the woman from hemorrhaging when she has her menstrual cycle. Okay? Now, when you do have a fetus, that some of the enzymes that are secreted by the trophoblast are going to send out little signals. And it's kind of an interesting process, really. Like I said, it's very reciprocal right from the beginning. And these spiral arteries are going to go through a process of remodeling. This isn't on your test, so don't worry about it. Where they get a little less kinked and a little less curly, and that lets the blood flow. Just like if you had a Foley that got spiraled around something, it would slow down or maybe even obstruct the flow. So those arteries have to go through a process of remodeling so that they can now give more blood to the baby. Okay? At the same time, the baby is making these little villi, and villus is the Latin word for finger. So these are finger-like projections. You look at them, they look like little tiny sprouted trees there. And what they're going to do is they're going to create these little craters in between. Let me point out right where I'm talking about. In between the villi, they cause a little bit of bleeding in there. That what happens is that mother supplies reservoirs of blood that are going to nourish that fetus. Okay? And eventually we're going to have the development of the umbilical cord. The umbilical cord, and when you guys see a delivery, if I'm around, I will show you the placenta and the umbilical cord, has 3 vessels normally. Now, you can have a 2-vessel cord, but let's not get too crazy. You have 2 arteries and 1 vein. Now, I'm going to show you guys a video. It's better than what I could do because I could not possibly draw lungs the way this guy did, but anyway, or heart, or liver. So I'll play this, I'll embed it in the playlist. The 2 arteries actually take the deoxygenated blood. They're the exact opposite of what you would think, and they pump it back to mom. Okay, but they're little tiny puny things, and you'll see them someday when you're on the floor. I'll kind of try and show you a little segment of cord after the baby's born. The 1 vein brings the oxygenated blood from mom into the fetus. Okay, so usually we think of veins as having the deoxygenated blood, but in this case it's the opposite. It's flip-flopped because the vein is actually carrying blood away from mom and to the baby. That's how fetal circulation begins. It gets a little more complicated. We bypass certain organs that we don't need as much, particularly the lungs, and I'll kind of go over that with you. And if you need to take more time with that in class, that's fine. But that's fetal circulation, or not fetal circulation, that's the development of the placenta and the umbilical cord. Amniotic fluid begins to be produced pretty early on. The functions of amniotic fluid, oh gosh, it's really making me crazy, are to cushion the fetus and the cord. You don't want cord compression. Remember, the cord is what's carrying all that blood to the baby. So the amniotic fluid kind of helps cushion the cord. It helps control temperature. So let's start making a list of all the things that amniotic fluid does. We can sing the praises of amniotic fluid. So it cushions the cord. It helps maintain stable temperature. It helps symmetrical growth. Now this is sort of, and the reason for that is it keeps the baby kind of floating in the uterus. There are syndromes where babies can get compression, and just like you would get like a compartment syndrome almost, that can happen in fetal development. In fact, there's a syndrome called amniotic band syndrome. You don't need to memorize it. It's not going to be tested. And you're not going to see it on NCLEX, and I hope to God you don't see it while we're in clinical. But the amniotic fluid kind of prevents that. It keeps everything floating freely so that the fetus has room to grow. Amniotic fluid can also act as a wedge during labor. Although, to be honest, generally speaking, things move a lot faster when you get rid of the amniotic, where you kind of break the membranes, so that the fetal head can act as a wedge during labor. But that is what your book says. And, this isn't really a natural function of amniotic fluid, but it does provide a fluid for analysis if you want to run tests. And again, we can talk about the chromosomal analysis. There are also chemicals in the amniotic fluid. Mostly we talk about lecithin and sphingomyelin, but we'll discuss those a little bit more when we start talking about prenatal assessment. So that's basically the function of amniotic fluid. And now for one last thing, I'm going to embed in your playlist a video on fetal circulation. When we get to class, if I can swing it, I'd like to have you sort of on the smart board draw the path of the fetal circulation. It's pretty interesting. All right, let me get that going.